Good morning, sir, and good morning, everyone. I'm presenting in behalf of Medicine One. My topic today is worm in the opal. So, case presentation is he's a 56 years old gentleman. He's a security by profession. He presented chief complaints of altered sensorium for 2 days and severe bilateral lower limb pain for 5 days. So, history of presenting illnesses was apparently well before 2 days. When he developed altered sensorium, it is in the form of irrelevant speech. But with that, he did not have any preceding history of headache, blurring of vision, fever, or witnessed episode of involuntary movements. There is no history of recurrent episodes of loose stools or vomiting. There is no history of abdominal pain or urinary complaints. Prior to that, past history, he had some preceding history of fever with upper respiratory tract symptoms for 4 days. This was around 5 days back, but it resolved. With that fever, he did not have any other localizing signs. And post fever, he only had decreased appetite. Other than the above mentioned complaint, he also alleged history of severe stabbing pain over the bilateral lower limbs for 5 days. And in view of the same, he has been non-ambulant. Past history is not a known diabetic or hypertensive. There is no history of past surgeries. He was a ethanol consumer prior with a history of around 20 years, has been abstinent from ethanol for 1 year, and he's a never smoker. So when he came to us, examination wise, he was vitally stable, but the blood pressures were borderline elevated. ED it is 170 bar 100, and the ward also it is 140 bar 100. General examination is confused, agitated. He is not oriented to time, place, and person. Person room air, no pallor, no icterus, cyanosis, clubbing, pedal edema, or lymphadenopathy. There was no rash or eschar. And there was bilateral lower limb severe tenderness on touch and palpation, but there was no local warmth or tenderness. And all peripheral pulses were palpable. So systemic examination, respiratory, cardiac, and para-abdomen examination was grossly normal. Going to CNS examination, higher mental function, he was not oriented to time, place, and person. No evident cranial nerve abnormality detected. Motor system examination, his bulk is normal, tone is normal, but bilateral lower limbs from proximal to distal, he has a power of 2 power 5, and alleged severe pain with movement and touch. And upper limb power is 4 bar 5. And reflexes bilaterally, triceps and biceps were 1 plus. And but in the knee and ankle, the reflexes are absent bilaterally, and plantar were mute. Cerebellar signs, he had no tremors and no nystagmus. Other signs, initially, it could not be elicited in view of altered sensorium. Had a terminal nuchal rigidity, but he was altered also. He was not much cooperating to our examination too, and gait was not able to assess. So initially, the differentials we consider for altered sensorium is he had decreased appetite for the past 1 week. So initially, we thought it could be any metabolic encephalopathy. Otherwise, it is a acute meningoencephalitis or septic encephalopathy due to any other systemic foci of infection. And on presentation, he had a borderline elevated blood pressure. So we also considered either it had any preceding history or any preceding press or hypoglycemic encephalopathy because he had decreased appetite too. But there is no noted hypoglycemic events in the ward, and blood sugars were within normal limits. And even also considered either he had any minor stroke and had an acute CVA. And for the severe lower limb pain, we thought either it is he had a I mean, we thought either it could be some dyselectrolytemia which would have caused the altered sensorium. Because of that, he would have developed severe muscle cramps or rhabdomyolysis, or he has been non-ambulant for a few days. So we thought either he developed any acute thrombosis or bilateral lower limbs, or any acute arachnoiditis with radiculitis. And lower down, we also consider either would have got any paresthesias in the early stage of Guillain-Barré syndrome, because his bilateral lower limb reflexes were normal, had a preceding history of fever 1 week back. So initial investigations, we went ahead. His HB was 15.1 and WBC is 12,400. He had a neutrophils of 77. Platelets were normal. Our renal function and hepatic function was grossly normal. Dyselectrolytemia, he had severe hyponatremia with a sodium of 111, with a serum osmolality of 235, urine osmolality of 395, urine spot sodium of 88, and the serum cortisol is 24. TSH is actually normal, but T4 and FT4 is borderline high. And initial CT brain, it did not show any evidence of hemorrhage or infarct. So then we suspected one of our differential we considered as a meningoencephalitis. We went ahead with the CSF analysis. So which showed a WBC of 140 cells, which were predominantly lymphocytic predominant, 73% of lymphocytes with mild eosinophilia, and RBCs were 6. And glucose is 53, proteins were elevated of 96. And other CSF analysis, cultures, expert MJET, multiplex PCR, VDRL, culture fungus, malarial parasite, bloodborne viral screen, everything were negative and non-contributory. But he had an elevated CRP of 66. And because of this lower limb pain, And he did not have any albinocytologic dissociation, and EMG was normal also. So initially we treated him with, for the dyselectrolytemia, we started him with 3% NaCl because he had severe hyponatremia. And we thought he was second, the altered sensorium was also contributing to it. So he started a 3% NaCl infusion, and he slowly improved. And also he was started on meningitic doses of antibiotics and antivirals. But with that, since the sodium, although the sodium improved, his sensorium did not improve much. He still had this altered sensorium. We went ahead with the MRI brain with whole spine screening, which showed imaging features suggestive of meningitis with few acute ischemic foci in the neuroparenchyma secondary to endarteritis. And there are few features of raised intracranial pressure. And also there are some features of arachnoiditis with post-contrast enhancement of cauda equina nerve root seen. So now what we did is, so we thought, so we would do a repeat CSF analysis to look for response, because there is patient clinically is not much improving. So went ahead with the repeat CSF analysis.
So what are your differentials at this stage?
It still thought he has got an meningitis.
You still thought it's a metabolic encephalopathy?
Many we thought it's a meningoencephalitis, sir. So maybe initially we haven't seen enough samples, so we thought we will repeat. In this picture, we thought it's a lymphocytic predominant. We still consider it as a tubercular meningitis with arachnoiditis, sir. So again, we did a CSF analysis. Now WBCs were increased, it is 192. And now the differential count showed predominantly eosinophils. So eosinophils of 55%, lymphocytes of 36, and CSF glucose is 61, and CSF protein has also increased to 128. So this is the previous CSF. So comparison with the same. So since this CSF is predominantly eosinophilic meningitis, so we thought we could evaluate for any other causes of eosinophilic meningitis. So you look for alternative causes. So usually eosinophilic meningitis, we can grossly look into either it can be secondary to infection, or it can be malignancy, or it can be drug related, or even autoimmune diseases can cause eosinophilic meningitis or other causes. So we again sent all CSF analysis expert MGIT were sent repeatedly. And in this time, we also sent parasitic analysis. So parasitic analysis, we sent qPCR for acanthamoeba, Balamutaya, and Negleria, which were negative. ANA was negative, and ACE levels were 32. But apart from that, we sent CSF Angiostrongylus qPCR, which is positive for Angiostrongylus cantonensis. So hence we came to a diagnosis of neuroangiostrongyliosis, and also had severe symptomatic hyponatremia, probably SIDH induced, and systematic hypertension. So here I'm going to talk about neuroangiostrongyliosis. So what exactly is this neuroangiostrongyliosis? It is also called rat lungworm. It is actually a zoonotic infection predominantly caused by rats. Rats are the definitive host. So how humans acquire this infection is, so human infection either occurs from deliberate or inadvertent ingestion of the third stage larva. So it will be either in the raw or undercooked intermediate host, or either it can be due to ingestion of some paratenic host. What exactly is paratenic host is? These are hosts. So actually the larvae will be inside the host, but life cycle will not be happening in those hosts. So snails, slugs, freshwater shrimps, crabs, frogs, toads, and monitor lizards. So if the people have any past history of consumption of this, we can consider they can gain this organism. And after ingestion, what happens is the larva will go into a body, will invade the intestinal wall and enter the bloodstream. So this organism has a very high neurotropism, very high propensity for CNS. So hence the most common site of migration will be central nervous system. So after going into the brain, what symptoms usually they have is they can have non-specific symptoms like mild headache to severe throbbing pain, nausea, vomiting, fever, meningism signs, and stabbing pain in the trunk and the limbs, which will be aggravated by touch. This is predominantly because of the radiculitis. Our patient had the stabbing pain in the trunk and limbs, which is aggravated by touch. Other symptoms, they can have cough, rhinorrhea, sore throat. The larva passes through lung and liver and lungs. And very rare complication is ocular angiostrongyliosis. The patient can have diplopia, monocular, blurred vision. So usually what happens is, it's a parasitic infection. Spontaneous remission usually occurs without treatment itself. But there are some serious cases, they can develop neurological sequelae, and even death has been observed. But overall, actually, it is a disease with good prognosis. And this is the life cycle. So as I said, this initially the definitive host are rodents. So the feces, the first stage larva will be passed in the feces, and there are intermediate host and paratenic host. So either consumption of the paratenic host or the contamination of food by the third stage larva can cause symptoms to humans. The humans are always a typical dead and aberrant host. Epidemiology wise, usually, is it common in India or not? Epidemiology wise, more common it is found in Thailand and China and Southeast Asia. But recent data shows it has been a geographical expansion of the parasite, resulting in a rapidly increasing incidence of human infection. And what about India? This is one of the case report. It is done in Indian subcontinent. What they mentioned, Indian subcontinent, which includes Sri Lanka, Bangladesh, Nepal, Bhutan, and India. So in this, what they come to say is, so they are included some 28 case reports, around 45 cases. So most of the cases in India, predominantly in the Kerala side, and India also there is two cases. One is in Puducherry and one more case, most predominantly in the metropolitan cities. So all of these cases, they have some correlation with monitor lizard consumption. So this is the case reports, and most of these cases have looked into if they have any past history of monitor lizard consumption. And this is an Indian study which also showed the Puducherry. There also they have made diagnosis based on the history of raw monitor lizard meat consumption, clinical presentation, and eosinophils in the CSF analysis. Our patient, actually, we asked, he had history of monitor lizard consumption around 20 years back, but currently he denied. And apart from this, there is some list. There is a list of records of angiotensin cantonensis, which is isolated from host apart from humans, from rats also. This is also in Tamil Nadu. They have isolated from rodents. They have isolated this organism. And this was other case reports which showed one is the previous one is in the done in India. So this is an elderly gentleman who presented with some paraparesis. He died, but later actually during autopsy they isolated the organism, and it can even present as an embolic stroke. So coming to another case review, which was done in Europe. So they have some 22 cases. In this case report, if they see, most of these people, they had some past history of travel. So you can see, so if you see in Europe, so almost most of these cases, predominantly they have traveled to Southeast Asia or in the Caribbean islands, they have traveled, except only one history. He did not have any travel history. So they consider it's like an autochthonous case or an indigenous case. And presenting complaints is predominantly of these people, predominantly 90% of people, they have headache, and paresthesia, dysesthesia, and anesthesia were present in half of the people. But fever less than 30% had fever, and neck stiffness and meningism is present in only 40% to 50% of the people. So diagnosis, how will we confirm the diagnosis? So usually, generally speaking, the diagnosis is very challenging. Isolating the organism in the CSF is very rare. It is difficult to isolate. It is present in only 2 to 11% of the cases. And serology analysis also, actually, it is not widely available. So in this European review, so mainly they made diagnosis based on the CSF analysis, and most of these people had CSF eosinophilia, around 18% in the 18% of people, and around 93% had CSF eosinophilia, and predominantly they had peripheral eosinophilia too. And elevated CSF protein is present in 92%, and low glucose was present in 38% of the patients. So will imaging helps or not? Ideally, literature review shows both cerebral CT or an MRI. Usually it is normal and reveals non-specific findings. Even if lesions are found, some authors found there is a predilection towards globus pallidus or cerebral peduncles, but there is no clear-cut evidence. Neuroimaging, if you consider, especially MRI, we can take it as a supportive, but not a decisive mean of diagnosis. So what is the treatment? So coming back to the treatment, as I said earlier, it is a parasitic infection. It's a self-limiting infection. But many authors, including Centers for Disease Control and Prevention 2019, what they advise is to go for a conservative treatment regimen with analgesics, steroids, and periodic removal of the CSF if required for relief of symptoms because of elevated intracranial pressure. And studies also have shown, prednisolone has shown to reduce the occurrence of persistent headache and lower the repeat LP for symptomatic relief. So it is a parasitic infection. So do we need to give antihelminths, yes or no? So this is still a debate. Theoretical consent showed whenever if you are giving antihelminths, the organism, the worms are going to die. So whenever the worms die, it is going to trigger a very severe inflammatory reaction in the brain and spinal cord. So in such case, it can cause exacerbation or worsening of the neurological symptoms. And studies also have shown the similar things. And there is one study, so which has compared adding albendazole to steroid will help or not. It shown no elevation of the headache. On the other hand, there are some positive trials also. So overall, if we see adding corticosteroids or using a combined regimen is still unanswered. It's still an unanswered question. So back to our patient, what we did our patient is, our patient is not specifically able to identify the mode of transmission. We asked if he have any history of Montreal lizard consumption, prawn stems, but he denied that history. But he had around his home, there is a lot of rats. So we thought probably it could be contaminated secondary to the, any fomites contaminated to it. He had eosinophilic meningitis, but did not have any peripheral eosinophilia. And CSF wet mount also, we are not able to isolate the organisms. So in our patients, we treated it only with steroids without antihelminths. We gave methylprednisolone 1 gram for 3 days, followed by once weekly injection methylprednisolone 500 mg for 6 weeks. Already had completed 2 weeks course. He is due for the 3rd week. And symptom-wise, his symptoms improved, symptoms regressed. He is able to walk now. Clinically and subjectively, he improved. So learning points is angiostrongyliasis and its association with eosinophilic meningitis. So if you are seeing a CSF eosinophilia, as I mentioned earlier, all those causes should be considered. Apart from that, if the patient has any history, contamination, with relevant to contamination with intermediate host or paratonic host, you should consider this also as a presumptive clinical diagnosis and should work for definitive diagnosis for it. And treatment, still a debatable thing, but better is always to go ahead with steroids without antihelminths. Thank you.
Thank you, Akash, for that presentation. So any patient who present with eosinophilic meningitis, your first differential should be a parasitic infection. And again, when you're presenting your clinical syndrome, I think if you give a unified clinical syndrome and differentials, that will be better.
Okay.
And of course, that history of consumption of monitor lizard and snails is important. I think we went back and asked that history, right?
Yes, sir.
Any questions? Amit, you want to add something?
Some data missing in what you presented. So this patient actually ended up getting 1 dose of albendazole.
Okay.
More as deworming before the steroids. We actually started him on empiric ATT before we got the diagnosis. So the albendazole, his headache actually worsened. Just 1 dose. And then the next day we got the diagnosis and started the pulse. In this patient, at least the headache seemed to have worsened after the
Yeah, again, in endemic areas, giving albendazole, becomes another question whether should we screen everyone for a NCC and then give albendazole. In the West they do it, but in our setting, we don't do that.
Yes, sir.
Okay, thank you.
Thank you.